right, Miltion Geivelas. I'm going to be talking to you about a little bit about tongue posture, ankyloglossia, craniofacial structure. They had wonderful presentations today, and there was things mentioned. Katrina, thank you for bringing up tongue ties, just at least to give me something to begin with. I'm actually one of the very few periodontists in the country that does that. I started, that's what I normally used to do. I still do some of it, but a lot less than I used to. And that's where I'm from. I have to show you the country of Aristotle and the Parthenon. And the person who started me on all this craziness, he just talked about it. That's Kevin Boyd. I used to take more days off. I used to take more vacations. That's all done. And I would say by choice, but not really. So all about the airway. And he showed me that time was about 2013, I think, or the beginning of 2014, that he had written that chapter. And Dr. Sheldon, who's here, I read the pediatric sleep medicine book. And suddenly something clicked. And I started I asked Kevin, I said, where do I fit? And he said, you know, the airway, the ADHD, the tongue being tied obstructs the airway. And then I went and I saw people that they used to do that before I did, for infants, for example, because I do all ages, from infants to adults. I started with Dr. Larry Kotlow, who I met at the ATP meeting, Bobby Ghaheri. Then I went to Tufts and I took the tongue tie course with Martin Kaplan. Then eventually I ended up with Scott Siegel, a wonderful man and a mentor for me in CO2 laser infant surgeries. And finally, at a meeting actually that again involved Mark and Joy, I met this guy who was a lot younger than me, but he had just finished his fellowship and he was working on his first 50 cases. And when I saw what he's presenting, I knew that that's what I was missing. So I got a California license, which is not the easiest thing to get, as you know. And I went there over a year and a half, probably 5 or 6 times, almost a week at a time. And I was the first affiliate resident. I work a lot with therapists. When I first started, there were very few, hardly any. The first person that I started working with, she's in this room, and that's Jenny Hobson. Hi, Jenny. Jenny, I met at the ATP meeting too. And then we developed a number of therapists that we're working with. And most recently, what was it, December, I think, of last year, we had a meeting with not all, but a lot of the therapists that we're working with. So in the Chicagoland area, we have a core of therapists that are probably, I don't know, maybe 20 or around that time that we're really closely and a lot working with, and then up to 40 that are the myofunctional therapists, most of them speech-language pathologists, some that are actual hygienists that we're working with. I don't touch anybody over the age of 8 months old without a therapist being on board and giving the okay to proceed with the releases. And up to 8 months old, the only reason we don't require it is because sometimes parents cannot afford it. We require lactation, but over 90% of the babies that I take care of, they do also have a myofunctional therapist. So of course you guys know about tongue ties by now. I'm not going to have to explain it, but I can tell you that that was the first person who talked about it, another Greek, of course. And you know how normal anatomy and breathing and open airway and how it can cause an obstruction of the airway. You very well said that the tongue posture should be on the roof of the mouth, you know, not on the floor of the mouth, in order to be able to breathe through your nose and breathe properly. And of course, the tongue is the scaffold of the maxillary arch to help it form. And when that doesn't happen, then we get V-shaped palates, high vaulted palates. And thanks to the therapists, when I get those moms with those kids or even those babies, they already know about this because either the IBCLC, you know, the lactation, or the therapist told them about it. And of course, the high arch palate means a narrow nasal cavity. So when the orthodontists are starting to expand that maxilla, then the nasal floor gets bigger and the nasal passages get wider. And of course, we have studies that started with Dr. Gimeno, and now, you know, we've got ankyloglossia as a risk factor for hypoplasia of the maxilla. And some rough numbers, you know, and like Kevin, you said, there's not absolute, but we know that usually we have to be wider. And sometimes it seems that we have the right width, but when you put the tongue into play, you really don't. And we need to expand cases that otherwise they might not seem that they need an expansion. The last few years we've been studying tongue tie versus tongue space because that does a couple things for me. Number one is that a lot of times, or a small number of times, actually not a lot of times, a number of times, we have kids or adults that don't have a tongue tie. We do the examination and everything, it doesn't seem to be tight. However, still they have very similar symptoms as a tongue tie. Now we're talking about tongue space, because if that cage that cages your tongue is not large enough, there's no space for the tongue to do what it needs to do and to move around freely so it can produce certain sounds or even block the airway. So this is what we're finding, that a lot of times the people have a tongue tie as well as a lack of tongue space. And then we have to decide what comes first. So when we look at a scan, for example, in this particular case, you can see there's space above the tongue, in order for the tongue to go up at least, and sometimes forward. There's a decent sized airway. So this patient, a lot of their problems might be related to the tongue tie itself. And then we proceed with myofunctional therapy and releases. And then you have somebody like this who has no space for the tongue whatsoever and very reduced airway. That's not the person that the first thing you have to do is not going to be to release the tongue. You're not going to get much of a benefit, and they might get worse if the tongue, although usually it doesn't back up, but there is a chance it might, and make their breathing and their sleep worse. So of course, myofunctional therapy, everything about it. It's not just, I try to explain to moms as well as patients that myofunctional therapy is not just a bunch of exercises so you can prepare for me to release your tongue. It's a lot more than that. So it promotes nasal breathing, lip seal, proper tongue posture, and correct swallowing patterns. And of course, it will prepare my patients for that lingual functional frenuloplasty. Like I said, I have to go fast. We have different protocols, but they're all custom for each baby, for each child, for each adult. There is no cookie cutter. So a lot of times, patients come to me from all different places. They might come from a myofunctional therapist. They might come from the lactation if it's a baby, but usually they come from a family member. They can come with all different knowledge. Some of them, they're very well aware. Some might come from Dr. Boyd, who recognized it, and then at some point of time, he refers the patient so that we can get working on it. So I do, of course, like the initial evaluation. We evaluate sleep and everything else. Then the radiology report as well as the radiology evaluation. And then, depending on where they're coming from, it takes a village. This is not a one-person thing. A lot of times they might have to see an ENT. If we think through their pediatrician, let the pediatrician know that on the scan, for example, or their symptoms, we find that they have enlarged adenoids or tonsils that are obstructing their airway. And refer them to an orthodontist, or sometimes to a sleep apnea dentist. One of the biggest things that I deal with, a lot of times I have to play the quarterback like Kevin does, or a therapist sometimes might do, is to what comes first and when do we do the releases if they're necessary. And that is hugely important, because even if you do the right thing, if you do it at the wrong time, it's still the wrong thing to do. So if you release the tongue or the lip or anything else at a time that the patient is not ready, or the mouth is not wide enough, or the airway is very restricted, unless there's a severe restriction of the tongue like a grade 4, I would like more space first. I want that cage to get bigger in order to house that animal that I'm going to release. So there are different, usually what I do is on babies, what I perform is a frenectomy. It's just a laser removal of the frenulum. In older children and adults, it's more like a frenuloplasty, and sometimes it can be 2 stages. Stage 1, if they are so restricted, like a grade 4, that they cannot really do their exercise to prepare for it, then I would do a quick laser release. I would do a frenectomy, and then follow that with a frenuloplasty. So of course, the purpose of the surgery is so that the therapist can take that patient to the next level. That's all I do. You can release all different ways. I prefer the carbon dioxide laser, and I'm not going to explain to you right now why, but that's what I use. But for frenuloplasties, when I go into deeper tissues, sometimes I do use scissors as well, besides the laser. So Dr. Zaghi became a friend as well as my mentor. And of course, we have anterior versus posterior tongue ties. Well, we call it that, but the anterior always has a posterior component. This is just so we can communicate. And a lot of times, especially on older kids, maybe teenagers and adults, there is some release of the superior myofascial fibers of the genioglossus muscle. So it is a partial genioglossectomy. Again, anybody that does that, they should know tongue anatomy. I will show you one that's a 70-year-old, but just to get an idea of a procedure of what a frenuloplasty, functional frenuloplasty is like. The 70-year-old has speech problems, forward posture, neck and shoulder pain. He was mouth breathing, had swallowing problems, headaches, migraines. The therapist was Kim. And you can see that lingual web, a tight lingual web, we call it, Eiffel Tower. And this is a frenuloplasty. So there's actually removal of the more superior fascia, the fascia and the septum behind the genioglossus muscle, and there might be a little bit of the genioglossus muscle that has been released. Then everything is undermined on the sides, but you can see that the Eiffel Tower is gone by working on the underneath of the tongue in that tight fascia and muscle, not requiring a second procedure. And this is closed. This is 2 weeks, 10 weeks. That's before and after. So you can see that the floor of the mouth is down now where it's supposed to be. You can see in the before that it was a lot higher. The floor was elevating with the tongue. And the 70-year-old has, most of his symptoms are gone, but now he's still working on speech. I do, and I think anybody should do age-appropriate releases. Not everybody gets the same thing. So an infant, of course, it's a frenectomy. We don't invade muscle or surrounding muscle or under muscle or anything like that. Then you go to kids that are, let's say, 2, 3, up to a certain age, and then you look at the demeanor of the child. You look at what is going on. And although most kids, especially the younger ones, they don't need a lot of muscle release or anything. It's mostly fascia. Some of them do a little bit, but we try to make it age appropriate because if there's a lot of pain afterwards or problems, then they won't do their exercises, then the muscle scars, and then even if you got 100% initially, you're going to lose a lot of it. So you got to be very, very careful how much you release, regardless if you're doing a frenuloplasty or not. And of course, older kids and adults, that's when we go crazy. No, I'm just kidding. No, you got to do the appropriate thing. That's what Santorini used to be. So again, we have level 3 evidence showing that grade 3 plus, functional cheloglossia is associated with alterations in orofacial morphology, restricted palates, tongue postures. There is a patient that actually, Kelly Wells, who's not here today, she is a myofunctional therapist and head and neck chiropractor, was the one that prepared the patient. That it's obvious what is going on, there are a lot of issues. And the orthodontic treatment was done by Dr. Ed, who's here. And again, you can see, the difference. So in this particular case, I had to wait for space. There was no space for the tongue. There was no point releasing that tongue in that palate that you saw with the high vaulted palate and the restricted. So after the area was expanded a lot, and now we're faced for the tongue, now the patient can prepare for it. And these are the symptoms. Suck the thumb at night, sleeps with mouth open, moves around a lot. Well, you can read the rest. Had speech issues, forward posture. There's the surgery. I didn't mess up. The tongue goes this way because when they're numb, sometimes they put it in weird positions, but on the 7th week, it was pretty straight. But you can see the caves there, and of course, orthodontic treatment is ongoing, but it is crazy. I mean, she sleeps with her mouth closed. She's not sore anymore. She's not tired. She's really a different child. But it takes a village. And this is the before and after. I mean, you can see the size of the palate. And this is skeletal expansion. This is not dental expansion. With another case that's a 9-year-old, has a lot of the similar issues, including chronic congestion. And this one, the therapist is Miltion Geivelas. She wasn't able to be here, but Hannah, her right hand is here.
Now I want you to say, or open your mouth big again and make your tongue go side to side. And now I want you to make your tongue go out and in, out and in. Nice job. And now I want you to try to lift the tip of your tongue up to the roof of your mouth. Opening was super, super wide. And there you go. All right, now do you think you can try and make a tongue click?
Couldn't do much. There was not much tone of the tongue. Right?
No.
So that was my evaluation. Significant restriction, restricted airway. There was a little bit of space, above the tongue, at least when you see the lateral. And you can see it there too. Although this kid, I'll mention it right afterwards, but although he seemed wide enough at about 35 millimeters, really the tongue was overflowing. There was not enough space. That's why he had all those problems. So the treatment plan was myofunctional therapy to prepare for the releases, proceed with the frenuloplasty of the lip and tongue. We use nitrous a lot of times with kids to just keep them more comfortable, which puts an extra work for the therapist because now they're laying back against gravity, which makes it harder to hold the caves and the exercises. And then they're numb, and on top of that, they're on nitrous that relaxes them. So, but they do very well if they're trained well. And then orthodontic treatment with palatal expansion. That's 2 weeks before the release. I'm gonna go fast on that. Then a few minutes before the release,
Good work.
now he's able to hold the cave so that we can do the release. So there was a lot of therapy that went the weeks before.
How are you feeling right now?
Yeah, they love nitrous.
How do you feel right now?
So this was the release. 6 weeks later. That's a week post-release.
And then a big oh my, look at that tongue lifting up right away. All your sutures fell out. Great work. Can you do?
I'm sorry, I gotta keep going. 2 weeks post-release, he's breathing through his nose throughout the day and night with a labial seal. 3 weeks post-release, he's sleeping with not waking up. 6 weeks post-release, he restarted. He had started before. He started his expander. He can do, now you'll see him here, this is with the expanders in his mouth, and you are. Dr. Danko is the orthodontist, he's doing the orthodontic treatment. The kid that couldn't do anything before, now he can actually hold his cage with expanders in.
Can you show us tongue to spot? And can you count to 10?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
With
Can
expanders
you
in.
bite down real hard?
That's why the list.
And open wide, 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 wide. Good.
Thank you very much, Milt, and thank you for your, leadership in this area.